So today I'm going to be talking to you all about assessment, clinical interviewing, and differential diagnosis. So my name is Natalie Horn. I work for Western Tidewater Community Services Board. I'm the manager over our same-day access department, and I've also worked in our school intervention program, doing assessments with children and families. So today we're going to cover the assessment process, building rapport with clients, clinical interviewing, common diagnoses that we see, and differential diagnoses, then ending with some practice. So, talking about biopsychosocial assessments, these are the type of assessments that we use when we're collecting information from our clients, especially at intake. We're trying to consider the interplay of biological, psychological, and social factors that contribute to their overall health and well-being and create their individual needs and individual circumstances. So this is a holistic way of looking at the individual as a whole to explore what best treatment options they need and what best suits them. So this is the way we create an integrated treatment plan to address all of their different individual needs. So these are the 14 sections of the assessment. This is pretty specific to Western Tidewater, the way this is structured. I know every CSB does it slightly differently, but we all tend to cover these different areas in order to get a holistic picture of the client. So we're going to go through each of these areas. So section 1 is the presenting issue or the reason for referral. So this is the symptoms section, kind of finding out everything about the client's current and past history with mental illness. Here we are getting into different sections such as depression, anxiety, psychotic symptoms, ADHD, oppositional defiant, manic symptoms, trauma symptoms, all broken down in different categories to see what applies to them and what doesn't. So here we're really finding out what brought them in specifically today. Why not last week? Why not next week? What's happening in this moment that they're looking for support on? And finding out as much about those current symptoms as we can, how often they're occurring, the frequency, how long they've been going on for, the duration, as well as their past symptoms. Even if it's something that they might not be experiencing anymore, what about in their past, to know about potential appropriate diagnoses for them. Maybe they have a history of schizophrenia, but they haven't managed due to medication or other treatment. So finding out as much about those symptoms as we can. And then going into their behavioral health history, we want to hear about if they've ever had any sort of mental health diagnoses in the past, whether that's from a doctor, a therapist, your CSB, a different CSB, just to inform our diagnosis to see what kind of history that they have, as well as exploring their medication history, specifically psychotropic medications, because even if they're unsure of maybe what diagnosis they've been given, if they have certain medications they're taking, that can give us insight into potential diagnoses they may have. Asking about any sort of hospitalization history. Have they ever been hospitalized for mental health reasons? And if so, when was that? How long were they hospitalized for? If they're able to recall what hospital it was and provide a release of information for us to get records from the hospital, or they might even have their discharge summary. So then we can glean, what was the reason for the hospitalization and what kind of diagnoses and treatment were they given there, as well as what was the hospitalization due to voluntary, due to suicidal ideation, or was it some sort of temporary detention order for other types of symptoms? Also exploring any sort of family history of mental health issues or concerns, because we know that genetic factors, many mental illnesses like schizophrenia and bipolar disorder can be genetic, so we want to hear about any sort of family history of mental health issues. And going into their previous interventions, so this is breaking down the last section a little bit more if they do have any sort of mental health history, finding out what kind of treatment they've had, breaking it down into different sections, whether that's psychiatry, individual therapy, group therapy, case management, intensive in-home, ACT services, and everything they could have experienced before with mental health, and finding out as much about those providers as they're able to give us. Who were they? When did they see them? If they're able to give that information, are they willing to sign a release of information so that way we can reach out to them to get their records and talk with them if it's someone that maybe they're still seeing, so that way we can ensure that treatment is consistent across the board. And finding out how they felt about those services. Were there things that were helpful, that weren't helpful? Are they looking to continue similar services or go in a different direction? And what was the result? Were they successfully discharged after meeting their goals? Did they have difficulty maintaining their participation in services because of transportation, timing? What was their engagement like? So getting as much information about their past as you can to inform your current and future treatment with them. And taking it way back, going into developmental history, exploring things about their upbringing, their birth. So if there were any sort of complications or complications with the mother's pregnancy or birth, and exploring how the client was during their first few years of life. Were they happy, want to be picked up, played with? What was their temperament? Were they quiet, more loud? Were they crying often, never crying? Kind of those things that might inform how they present today. And were their basic needs met? Did they have access to food, water, shelter, and their physical or emotional needs? Like, was someone there to pick them up when they were crying? How did they feel about their childhood and upbringing? And that can give us some insight into potential childhood trauma, neglect, or abuse that we'll explore later. But that kind of is the first indication there that we might want to go back and explore trauma with them. And then lastly, did they meet their developmental milestones on time? Walking, talking, toilet training. And oftentimes they're like, I don't know why you're asking me this. I don't know. I'm a grown adult, but knowing things that might have been delayed in young years can impact us in the future. But also maybe knowing something like, oh, they had a speech impediment, but they participated in speech therapy, and this is no longer a concern. And going into education and vocational status. So depending on the age of the client indicates which part of the section you're going to spend the most time on. So regardless of age, you're going to want to explore their education history. If it's an adult, what was the highest level of education that they completed? Was it high school, college, vocational school? And were there any sort of concerns with behaviors or grades, academics, and how did they do in school? And then for kids, definitely exploring even more into this category because oftentimes the mental health symptoms will be present in the school setting and sometimes exclusively in the school setting. So what is school like for them? How are they doing both socially, academically, behaviorally? Are there behavior concerns? Are they getting suspended, referrals, expelled, being sent to an alternative school? How's their attendance? Are they going to school every day on time, or are there issues of truancy, skipping school, because we know that that can be part of their presentation? How do they do socially? Do they seem like they have friends, get along well with their peers, or are there concerns for bullying, things like that? And lastly, asking if there is any sort of special education in place, whether that's a 504 plan or an IEP. And that can also help inform our diagnosis if we know there is already a documented diagnosis of something like ADHD or autism, and pulling from that school evaluation that they might have. And then if someone is of working age, exploring their employment, their job history, what's their current employment status, full-time, part-time, unemployed and looking for work, not looking for work, retired, on disability, and finding out as much about their employment history as they're willing to share, even if it's someone who's older, maybe they've been retired for 10 years, but seeing what kind of jobs they've had in the past, because that can glean insight into their interests and their strengths. And if they are working, what is that job like for them? And how long have they been there? What kind of jobs have they had in the last few years? And has their mental health been a barrier for them to maintain or obtain employment? And lastly, military status, finding out if they themselves have ever served in the military, or if it's a child or a spouse of someone in the military, in what branch, because this does go to state reporting, so we can see what kind of population that we're serving, as well as making sure they're linked with the appropriate resources like different veterans and service member programs that we might have at our CSBs. And then current living situation, family history, relationships. Finding out about what's the client's living situation. Are they living alone? Are they living with roommates, family members? Are they living independently or dependently on others? Is it an apartment, a house, a group home? Finding out as much about that as you can. And how do they do in their household? Are they able to do their laundry, dishes, create food, meal prep, things like that? If they're a kid, are they able to do the chores that are asked of them, like cleaning their room, sweeping, taking out the trash? Are they maintaining their hygiene independently, showering, brushing their teeth every day, eating well, 2 or 3 meals a day, sleeping well, and are they more messy, clean, disorganized, organized? And then exploring what kind of financial resources they might receive. We'll often know what kind of insurance they have coming in, whether that's Medicaid or something else. And if there's any sort of food stamps, SNAP, SSI, SSDI, to get a good financial picture, and asking them how they do with managing their money. What do they tend to spend money on when they have it? Are they able to buy groceries, pay their bills, or are they having trouble meeting their basic needs due to financial concerns? And then the next section is pretty broad. It tends to ask what are any issues with like family conflicts or past trauma history. So I like to pose this in a very general way to kind of open up the floor for them to share anything that they've experienced that might be important to know about. So what kind of experiences have they had in the past? Was there any sort of childhood trauma or recent traumatic experiences that they've had, or even stressors, whether that's conflicts with certain family members or children, things like that. And then just finding out about their support system, like who lives in their household, especially if there's minor children, how old are they? And even if they have minor children that might live outside of the home, finding out, their situation, who they're living with, and what's the result of that. And section 7, we're going into legal status. Oftentimes we'll know going in if a client is court mandated for treatment or assessment, or if they're there voluntarily, but clarifying that, seeing if there is any sort of court order, whether that's for just the assessment or the assessment plus treatment, and seeing how they feel about that. Oftentimes, if they're court mandated for treatment, they might not be too thrilled about talking about everything going on with them, might not feel like they need treatment, but still trying to give them as much autonomy as they can to make decisions regarding their treatment. So regardless of if it's court mandated or not, exploring any legal history, any past arrests, charges, incarcerations, and knowing that that can be indicative of trauma as well. We often have clients coming in who've recently been released from jail or prison, looking to kind of get back on their feet. So seeing what kind of services we can offer them. And if they are on probation or parole, getting information on their probation officer, if they're willing to sign a release of information, so that way we can correspond with them to inform them that they are engaging in treatment or following the recommendations that we have. Also asking about any sort of legal concerns in the family, if anyone else in their family has recently been, arrested or incarcerated. And I think this is important regardless of age. If it's a child, that can be very impactful if someone they're close to is incarcerated just as much as if you're an adult and maybe your spouse or a friend or even a child is incarcerated. And then also seeing any other legal things to know about, whether an authorized representative or being legally incompetent, to make sure everyone that needs to be involved in the assessment and in the treatment is present. And then the drug and alcohol profile, this could be its own training in itself with the ASAM and exploring drug and alcohol substance use. This will just be a brief overview. So exploring if they have any sort of current or historical use of substances, whether that's alcohol, marijuana, stimulants, opioids, cannabis, even caffeine can be characterized as a mental health disorder, depending on how it's impacting them. And if there is any sort of current or past substance use or abuse, finding out about that, when they first started using that substance, how often are they using it? Is the amount that they've been using increasing, decreasing over time, indicating an increased tolerance? Have they had unsuccessful attempts to cut down on using the substance? Ever experienced cravings, withdrawals, or failure to fulfill major roles, or just general negative consequences from their substance use? And is their substance use related to their current mental health presentation? Do they feel like they're using substances to help cope with their mental health symptoms? Have they noticed an increase, decrease in symptoms since using substances? And then assessing for their stage of change. Is this something that they're willing to work on at this time? Are they here because they want to be abstinent from substances? Or is it something that they don't feel is an issue currently, regardless of if there might be evidence otherwise? And then also exploring any sort of family history of substance abuse, because we know that addiction can be genetic. So finding out if someone in their family also has a history of substance abuse, that can make them more likely to develop substance dependence. And then going through the ASAM, which again could be its own training, the 3 different sections, their immediate needs, their risk rating, and then determining the level of care, whether that's monitoring, outpatient, intensive outpatient, partial hospitalization, and inpatient treatment. And then going into what I would like to say is my favorite section of the assessment because it's more strengths-based. I feel like everything leading up to this has been very deficits-based. What are the challenges, the issues that the client is having, where this is really where you get to know what their interests are, what their passions are, and the things that protect them and keep them going. So who are their support systems? What are the people that are in their life that they can call on, that they can go to if they are having an issue? Is that family, friends, children, supports? That could even be, pets, things that they're caring for. And then what are their strengths? And I like to frame this to them as anything that they feel like they're good at, that they like to do, or that people might like about them. It can be anything from video games to sports to being hardworking, to being caring. So anything that they see as a strength of theirs, and then any future goals that they might have. For children, I like to ask, what do you want to be when you grow up? And for adults, it can be anything short-term or long-term, whether that's getting a new job, obtaining housing, going back to school, and then exploring their family strengths. What are the things that they like about their family? And this can be whatever they do consider their family. It doesn't necessarily have to be biological or nuclear family. This can be a partner or a child, however they see their family and how they support them. So these are all very important to see what kind of protective factors the client has and the motivations that they have to improve their mental health. And then we're going to go into the mental status profile. And although it's a discrete section, this is something that we're assessing for throughout the entire assessment. So here we are describing how the client is presenting to us throughout the entire assessment, from their behavior, appearance, attitude, mood, speech, thought process, cognition, insight, and judgment, as well as kind of going back to those things we talked about. What are their protective factors and what are the risk factors for things like suicide or homicide, and any concerns with cognitive impairment or delay. In our assessment, there's a mini cognitive status exam that will pop down if you do have any sort of concerns for dementia or Alzheimer's, that ask the client to remember 3 objects, apple, table, and penny, and then ask them questions to see how oriented they are. What day of the week is it? What month is it? What year is it? And based on that can tell if there is a risk for that cognitive impairment. And so going more into the mental status exam, this is our indifferent opinion about how the client is presenting to us during the assessment. So what's our first impression? Are they appearing well-groomed, normal? Are they disheveled, malodorous? What was their behavior like throughout the assessment? Were they active, engaged, acting as you would expect? Was there any sort of psychomotor activity, whether that's extra or not enough? Was their eye contact appropriate? And did they seem like they were responding to any sort of internal stimuli, maybe laughing inappropriately, talking when they weren't asked questions? Was their speech appropriate, normal, or was it slow, rapid? What did they say their mood was? How did they say that they were feeling, doing, versus their affect of how we noticed them presenting? Were they, happy? Were they depressed, anxious? And were their thoughts pretty goal-oriented, focused on the questions that we were asking, or were they having some sort of flight of ideas, thinking about and sharing thoughts about things that maybe weren't related or disorganized, where you couldn't keep up with what they were saying or what they were thinking? Any sort of like delusions or obsessions that they expressed? And did they seem like they had good insight into their symptoms? Were they able to express what was going on, or were they someone maybe who is court mandated and said, I don't have any sort of mental health symptoms or concerns at this time? And then also going into the Columbia Suicide Rating Scale, the 6 questions to assess for suicide, see what kind of risk there is, if there in the last month has been any wishes of going to sleep or wish they could be like dead, and then if they've ever had any sort of actual thoughts of killing themselves with a plan, means, or intent in the last 30 days, as well as that lifetime history of suicidal behavior. And depending on how they rank, we know that we might need to seek emergency services or just give them those if they might be at moderate risk. But For us, we always make a crisis plan no matter what the risk level is, even if there's never been any sort of history of suicidal ideation or behavior. So exploring with the client, what are they like when they're doing well? What are they like when they're not doing well? Who would be their emergency, crisis contact? What are their coping skills? What makes them feel better? And if they ever did have to be hospitalized, do they have a preference in hospital that they like to go to? And then you're going to take everything from the assessment to create and formulate a provisional diagnosis. So throughout the assessment, you're probably coming up with some sort of working diagnosis that you're looking for additional evidence to support or dispute and create a new diagnosis, whatever you think is at the core of the client's presenting problem. And this can be multiple things, this can be one thing. And it's really important to make sure that you're checking with the DSM-5 when you have a diagnosis to make sure the client is meeting full criteria. Personally, when I do an assessment, I like to have it up. And if I notice the client is reporting anxiety symptoms, going through things like generalized anxiety or social phobia to see what best fits, as well as processing with supervisors or peers in the field if you're not sure about a diagnosis, as well as using Z codes. And although they're not billable, these are a good way to indicate to other people working with the client other issues that might be of important clinical attention, other things that are impacting clients, such as maybe a recent disruption of their family by separation or divorce, a death in the family, a history of neglect or abuse. Pretty much there's a Z code for anything you could think of. And then you're going to select if the client is at risk, has a serious emotional disturbance, a serious mental illness, or none. And this is also for state reporting to see what kind of clientele we have coming through, as well as indicating, are they someone who has a serious mental illness, or are they experiencing adjustment disorder, which wouldn't constitute a serious mental illness for an adult. And then most of these are based on age, whereas like at risk is under 6 years old, SED can be up to 17, and then SMI is in adulthood. So pretty much here, you're taking everything that you've gathered, all of your professional and clinical judgment to come up with the best and most appropriate diagnosis. And then writing everything up, pretty much your whole thought process from the diagnostic section to create a summary of what this client came in for, who they are, and what kind of recommendations you have. I like to think that this is the section that is the most important. If someone were to only read this from my assessment, would they have a good idea of who the client is and what they're looking for? So giving kind of a brief overview of the client, who they are, their age, their employment status, where they're living, what they came in looking for, and how did they present during the assessment? Were they active, engaged, with good, moderate, poor insight? And then listing out all the symptoms that you've gathered from them, both from their self-report, what you've noticed as well, and then notating the provisional diagnosis that you've given, as well as the recommendations for treatment and what they then accepted or declined. So pretty much in the summary, it's important to make sure that your diagnoses are justified, that if someone were to question why you gave them a particular diagnosis, you're able to point in the summary and in the symptoms for the criteria that they meet to have that diagnosis. And then the recommendations and treatment goals section. So here you're documenting everything that they qualify for based on the information that you've gathered from them, based on their diagnosis, all services that you think they could benefit from, whether that's therapy, case management, peer support, or a higher level of treatment like our assertive community treatment or GERO, TBI, and making sure you explain those services thoroughly to them. What those mean, what a day-to-day would look like with those services, how often someone's reaching out to them. So that way they can make an informed decision about what services they actually do want to receive. And creating basic goals for them first, like engaging in treatment, engaging in therapy, building rapport, and moving on from there. So pretty much making sure you document what you recommended and what they accepted. And this is the way you're kind of closing the first chapter of their mental health journey in order to schedule their follow-up. So that way they've gone through the assessment process, been given diagnoses, and then have their follow-up care scheduled. And also the medical, depending on what kind of document you're doing, this can be its own separate document or it can be within your clinical document. So making sure that you're aware of the client's physical health history, because we know that mental and physical health go hand in hand. So we want to hear about any medications that the client is on, mental health or otherwise. If they have any sort of allergies, when was the last time they went to their primary care doctor or for a dental checkup? And then any current medical conditions that they have, whether that's diabetes, high blood pressure, cancer, just any sort of physical ailments that might be impacting them, as well as any history of serious illnesses or injuries, whether that's hospitalizations or broken bones. Um, and then exploring any sort of injury to the head or neck. Have they ever had a traumatic brain injury? And that can be really important because we do have programs specifically for clients who have experienced a TBI or other neurocognitive disorders. If they're female, exploring their pregnancy history, if they've ever been pregnant, any complications or concerns during those pregnancies and the outcome of those, screening for tuberculosis, and then asking if anyone else in their household has any sort of medical conditions that might be impactful to them. For example, like a child who might have a family member with a medical condition that can be stressful for them, or an adult who might be a caretaker to another family member. That's a stressor that might be impacting their mental health. So finding out as much about their medical history as you can to see the connections between their mental and medical concerns. And I just put another section here for state reporting. I know for us, these specifically go to the state and they need to be consistent. So if it's SMI, SED, at risk, arrests in the last 30 days, the education, employment status, SA issues, as well as military status. And I know we'll get kickback if anything is inconsistent, like say you put here, they've had 4 treatment episodes, but there's none indicated here throughout the SA problems. That wouldn't be consistent because even if they weren't currently using any sort of substances, they have in the past, and you can indicate that. So now that we've gone through all the different sections of the assessment, we're going to talk about clinical interviewing. So the way that we're actually gathering this information from a client. So we're having a structured conversation with them to gather comprehensive information about their functioning, history, and current concerns in order to inform our diagnosis and treatment. And the focus of clinical interviewing is, first of all, why is the client looking for help or assistance? Why now? Like I said before, why not last week, last month? Why not tomorrow, next week? What is happening in this exact moment that they need support with? And making sure there are resources available that can help the client with their presenting problem. I know through our same-day access, we often have clients come in where their only current desire and need is housing. And although we can connect them with case managers, permanent supportive housing, we're not able to give them, a hotel to put them up in for that night. So making sure that they're aware of potential outcomes of the assessment, that we might be able to help them with that need down the road, but we might not be able to meet that immediate need. So making sure that they're aware and willing to engage in the mental health assessment, or if that's something they want to come back to later when they do have that basic need of housing established. Rapport building is key, building that relationship with the client, which we'll talk about, and partnering with the client, making sure you're dispelling kind of that power dynamic, especially if it's someone who's never been in treatment before. They might be anxious or nervous, and trying to make the playing field pretty even and show that you're there to find out about their world, that you're not the expert, they're the expert into their own lives. Going through all areas of the assessment, and then keeping the interview semi-structured, like using open-ended questions to gather deeper information, but also allowing the client to take the reins. If they want to just talk and tell some stories that might be indicative of their mental health issues, it doesn't have to be step by step through each section in order. You can kind of flow through and gather things, copy, paste them where they need to go later, but allowing for the client to guide the way of what order they want to talk about things. And like I said, building rapport is one of the most important portions of the helping journey. So this is our way of developing a meaningful connection with clients where we show respect, understanding, awareness, involving effective communication, empathy, and genuine interest in the other person. I'm sure we've all heard from a client, oh, you're only doing this because you get paid. when we know that's not the case, that we are doing this because we actually care and have interest and a desire to help them. So making sure that we convey that, however that might look for the individual client, to show that you are interested and invested in them and getting the help that they might need. So tips for building rapport with clients. First of all, using nonverbal cues to convey warmth and understanding. So, making eye contact, leaning in, being aware of your body language, coming closer when appropriate. Breaking the ice with small talk, not just introducing yourself and launching straight into the assessment, asking them about traumatic experiences or symptoms, allowing for them to warm up at their pace, breaking the ice, as well as integrating humor as you feel is appropriate. If it's something you feel like the client will respond to and something that you feel comfortable using, sometimes it is nice to, make some jokes and get things going in that way. Showing empathy and compassion, especially when the client is distressed. We oftentimes have back-to-back sessions, assessments, and we're eager to get through them, but we do need to take a step back and notice that this is the client's 2 hours that they have to express what's going on, to have their needs met. So pausing if needed, giving them space, holding space for them, even offering them a break or a tissue, whatever they might need. Avoid being judgmental, leaving our biases at the door, even if it might not be something that we're in agreement with. We can still listen and be empathetic to the client. Treating the client as a partner and collaborator in the treatment process. Again, dispelling that power dynamic, allowing for them to be the experts into their story and their lives. Fostering their sense of self-efficacy, allowing for them to ultimately make the decision on their treatment of what they feel like is best for them at the time. Attending to their nonverbal cues, seeing if there are discrepancies. Maybe they're saying that they're fine, there's no issues going on, while at the same time they're tearful, kind of pointing that out and exploring with them where that disconnect might be. And making sure you're understanding what they are saying to you by reflective listening, paraphrasing, active listening, so that way they feel like their story is being appropriately heard. Making sure you're not allowing for disruptions, distractions. I know we're all busy and in crowded environments, but making sure you're in a closed and quiet space, putting a sign on the door so maybe no one will disturb you, not checking your watch, just being mindful of how you're presenting and maintaining a positive, enthusiastic, supportive attitude. Even if a client might not be happy to be with you, you can still offer them an enthusiastic environment. And using positive affirmations, especially if it's a client's first time seeking any sort of treatment, they might not know what to expect or if they're doing things right, even though there is no right or wrong way, but encouraging them that the information they're sharing is helpful and will be necessary for their treatment. Making sure you clarify their confidentiality, privacy rights, making sure they're aware that everything they share is private and confidential unless there are concerns with safety or harm of themselves or somebody else. Making sure your environment is peaceful, private, trying to avoid technical jargon. Just because we all know what certain clinical words mean doesn't mean the clients do. So breaking it down in a way that they can understand, whether that's the treatment modality or their diagnosis, just trying to ensure that they are aware of what they're actually agreeing to. Especially for diagnoses, I like to make sure they're informed about the diagnosis that I'm providing and give them some information on it. Like, this is disruptive mood dysregulation disorder, and these are some of the symptoms that are characteristic of it that I also noticed in you. Do you feel like that's appropriate? Do you have any other thoughts about that? Being flexible and open-minded. You don't have to go through the assessment section by section. Like I said, you can kind of jump around, see what works best for you, as well as the client. If they just kind of want to talk, you can type it up, paste it in where it needs to go later, using open-ended questions to get as much information as possible and not moving too quickly. Start with ice breaking and proceed through the assessment, like I said, at the client's pace in kind of the order that the client seems like they want to go, and just being aware of your tone of voice. And then motivational interviewing, we use components of motivational interviewing in order to gather information during the assessment. And again, this could be its own 2-hour training. So just a quick slide on it to use the principles. We're going to express empathy, show that we're listening, that we have genuine care and interest. Roll with resistance. If there's something that the client is adamant that they don't want, we're not going to try to convince them. We're going to respect their autonomy and self-efficacy. but also develop discrepancy. If a client says, oh, I don't need any sort of substance use treatment, I don't have any sort of substance abuse concerns. However, they recently received a DUI, kind of pointing out that difference, that discrepancy, and seeing what they might have to say or think about that. And then ultimately supporting their self-efficacy, their right to decide their treatment, and have information on their diagnosis. So pretty much with motivational interviewing, we're trying to increase their motivation to commit to change. Our role, especially, is to have them say things out loud, their goals, their motivations, because we know if someone does say those things out loud, they're more likely to reach those goals. So now we're going to watch a quick video on rapport and building clinical interviewing skills. And afterwards, we're going to reflect on what kind of skills we saw and what we might want to implement into our own practices.
Right now, I think after having seen that car accident, and now the way that I feel just when I'm in the car, that now I don't even really want to get in the car. I know it's very stressful for me to even drive to work, but I mean, it's my job. I have to get there. I don't really drive any other place. I live in a community where my grocery store is right down the street and my dry cleaner, but I don't drive to go see friends. I'm just, I'm just sort of paralyzed by this fear that even though I wasn't in that car accident, that that I could die in a car accident.
This is causing significant distress.
Yes. Yes, I would definitely say it's significant.
Yeah.
And
affecting your behavior. With things you normally do.
Yes, I don't go anywhere other than to work. It's very stressful for me to even get to work. I don't go and see my friends. If they come see me, that's fine, but I don't really want to get in the car and drive anywhere. And I sure don't want to get in the car with somebody else. And I've got this trip coming up. My family lives just a couple hours down the road, and I need to drive home. Can't catch a flight, but I'm not even sure that I'm going to be able to go home for the holidays because I cannot imagine driving on the highway for 2 hours.
So yeah, again, it's just significantly you've witnessed this traumatic event, which would rock a lot of people's world, and it sounds like that's what is happening right now. And so I guess kind of at the halfway point, of this session here, I'm wondering if maybe I can just summarize a little bit what I'm understanding. You say, you're talking about feeling anxious. Okay, if I take a note or two.
Oh yeah, sure.
Talking about feeling this anxiety in different areas of your life. You had mentioned that the feeling anxiety, in fact, it's limiting you. It's you're having some thoughts about should not be over this by now.
Yes, and I wasn't even in the accident. So why am I so affected by it?
Right.
I should be over this by now. I shouldn't be so disrupted.
A lot of shoulds. A lot of I should be better. Why is this happening to me?
Yeah, why can't I handle it?
Okay. Why can't I handle this?
Yes.
Yeah. And then, as you mentioned, the behavior is that you're no longer doing some of the things that you enjoy, and even when you are driving to work or whatever, it's very problematic. It's anxiety provoking. You get to work and you're a wreck. Sorry for the wording, but
yeah. I mean, it's like I was saying. I can feel my chest tightening up, and my heart rate accelerates, and my hands are like sweating as I'm holding on to the wheel, and I can even hear the sound of like brakes squealing. They're not, but I can just hear it in my mind, and that sound of cars running into each other, and my muscles feel so tight that they could pop, and it's just hard to swallow. I mean, it's just a struggle.
Okay. So if we can kind of see this as a little bit of a pattern, kind of a cycle that's happening, not a pattern in your life, but kind of how it's working, it seems that the anxiety, the fear, and so forth that you're feeling is causing you to question yourself and your ability to be able to function, and you're starting to kind of wonder and maybe have some thoughts that are not so productive.
Yeah, I feel like weak or
Yeah.
So after that, I'd love to hear from you guys in the chat of different rapport building techniques that you noticed being used by the clinician, if there are anything that you would have used that wasn't used, and anything from the video that maybe you haven't tried that you would like to try. Summarizing, active listening, reflective, clarifying, validating. Yeah, seeing a lot of the active listening and the nonverbal cues. So not as much about necessarily what he's saying, but just showing that he is engaged with her. Is there anything that you guys didn't see that you feel like could have been used? Listening, showing empathy. And I know he even said, oh, he made like an error interrupting her or making a joke that was a little insensitive to her actual situation. Encouraging psychoeducation. Yeah, that would definitely be helpful to know that this is normal and what to expect moving forward. So now we're going to go into diagnosing and differential diagnoses. So we've talked about actually giving a diagnosis during the assessment, but I want to go through common diagnoses and how we actually do that. So as we know, diagnosing in social work, in clinical work is the process of identifying and classifying different mental illnesses by assessing and understanding the interplay of symptoms, history, and context of an individual to determine the most accurate diagnosis. Where is their current issues coming from? Where is it stemming from? And what's the most appropriate way that we can explain that or categorize that? The steps for diagnosing are, first of all, doing like we did before, assessing the client's symptoms to determine their problem, the core of it, where is it coming from, collecting information through as many different means as we can. That's our clinical interview, our observations of the client and the symptoms that we're noticing, psychological tests, maybe a psychological evaluation that they have on file, and interviews with others if possible. If it is a child, maybe their parent that they came in with, or if it's an adult, a parent or another family member that are there with them. And determining a label or diagnosis based on what's considered normal or average. I think we all have that kind of clinical instinct when we see someone who might be reacting in a way we would expect to a certain event versus what is above the norm or the average. So kind of determining that border with someone who might just be experiencing a hard time versus an actual mental illness. And then using multiple diagnostic tools and methods in order to inform our diagnosis. So not just our clinical interview, but integrating other tools in our assessment, such as a HUDAS or a DLA-20, in order to assess their level of functioning and also see how that changes throughout treatment. And being mindful of any ethical considerations when diagnosing clients, because we know there are certain populations where different diagnoses are overdiagnosed. For example, in young Black males, they tend to be overdiagnosed with ADHD and ODD. So making sure when you are providing diagnoses like that, there isn't any sort of bias there and they are meeting appropriate criteria. So the big eight, I'm going to do a really brief overview of the most common top 8 diagnoses that we see within a CSB population. And this is not all exhaustive, and a whole course on the DSM could be a semester-long course. So this will be just a toe dip into different diagnoses. So first of all, neurodevelopmental neurocognitive disorders. So these are types of disorders that impact how the brain functions and alter development and can cause difficulties with social, cognitive, and emotional functioning. Within this category, we have intellectual disability, global developmental delay. We have language disorders such as speech, sound, stuttering. We have different motor disorders such as tic, stereotypical movement, autism spectrum disorder, as well as ADHD, which I think we often forget is in the neurodevelopmental neurocognitive disorder category. Then going into our schizophrenia spectrum and other psychotic disorders. So here we have a variety of different disorders that are considered to be on a spectrum instead of discrete individual diagnoses, such as schizotypal personality disorder, delusional disorder, brief psychotic disorder, schizophreniform, schizoaffective, and schizophrenia. And regardless of where on the spectrum it falls, these disorders are characterized by both positive, negative, and cognitive symptoms. For our positive symptoms, these are things that are present that should not be there, such as thought disorders, hallucinations, delusions, paranoia. Then we have those negative symptoms, things that are missing, that should be there, that you would expect to be there, but are not. such as expressing emotion, lack of motivation, isolation, maybe catatonia, and disinterest in day-to-day life. And then the cognitive aspect, difficulty with attention and making informed decisions. And so oftentimes with schizophrenia spectrum disorders, they're characterized by how long symptoms have been going on. So going back to the first section of the assessment, that's why it's important to know duration and onset of symptoms to make an appropriate diagnosis. For example, brief psychotic disorder is that initial onset of psychotic symptoms up to 1 month, whereas schizophreniform is that 1 month to 6 months, and we wouldn't diagnose schizophrenia until there is 6 months or more of symptoms. Going into bipolar-related mood disorders. So bipolar disorder is characterized by extreme mood swings to include mania and depression. And we know that there is some sort of genetic component to bipolar disorder, although they're not fully understood currently. So we're going to talk about depressive disorders in the next slide, but a manic episode can be characterized by someone being overly energetic, feeling on top of the world, overly happy, feeling like they can do anything, maybe not sleeping for multiple days, talking very fast, rapidly with like a flight of ideas, being very easily distracted, having a flight of ideas, as well as kind of doing things that they wouldn't normally do, engaging in risky behaviors, maybe gambling, using substances, sexual activities. So for bipolar 1 disorder, this only has to be characterized by a manic episode lasting 7 days or more, whereas bipolar 2 disorder is characterized by hypomania. So those are manic symptoms, but not meeting criteria for a full manic episode lasting at least 4 days, with also episodes of major depressive disorder. And lastly, we have psychothymic disorder, which is those hypomanic and depressive symptoms that last for longer, and they kind of go day to day in between. So they are longer and they go through most days for over 2 years. So it's that cycling between depression and mania. And going into depression, feelings of sadness, loss of interest, affecting how we think, feel, and behave. There can be chronic emptiness, feeling sad, hopeless, restless, changes in sleep, appetite, isolating, no interest in things that they usually used to enjoy, feeling hopeless and guilty. So of course, with those, that tends to characterize major depressive disorder. And then we also have disruptive mood dysregulation disorder, which is a childhood disorder. And we often think about this more as a conduct disorder, although it is under the depressive mood category because it's characterized by that irritability, that low mood, with those outbursts, whether that's physical or verbal, but frequent outbursts that children might have that they're not able to control and they're irritable most of the time. This DMDD can also be a precursor for bipolar disorder in adulthood. Then we have persistent depressive disorder, which is similar to major depressive disorder with similar symptoms, with a little less intensity and going on for longer, multiple years. And then premenstrual dysphoric disorder is those depressive symptoms around menstruation. And anxiety disorders are characterized by fear, dread, and just feelings of anxiety and nervousness that are out of proportion to a situation. There's frequent worry that can't be controlled or made to go away, avoiding doing things or socializing because of those anxieties or there's fears, panic attacks or fear of a panic attack, feeling, having nightmares, flashbacks, trauma, things of that nature. So we have generalized anxiety disorder, which can just be about anything and everything. We have separation anxiety disorder, either in childhood or adulthood, where someone is fearful of being separated from someone close to them or their caregiver that prevents them from doing things that they need to do, going to school, going out of the home, sleeping alone. Selective mutism is a childhood disorder where we see kids that we know are able to speak, but do not in certain situations because of anxiety. Then we have specific phobias that can be to anything from water, heights, spiders. And I know we all have different things that we are afraid of or don't like. Like, for example, I don't like spiders. If I see one, I will scream, I will squash it with my boot. But if you have a phobia, that is something that's actually impacting your functioning. So if you had arachnophobia, you would be avoiding situations that you would see a spider and it would be causing difficulty in your day-to-day life versus just our normal typical fears of something. Social anxiety, that fear of socializing due to worrying how people are going to perceive you, that you're going to embarrass yourself or others will judge you. And then agoraphobia, that fear of situations where it's difficult to escape or get help, like public transit, closed, open spaces. Then trauma and stressor-related disorders, we tend to think about this as PTSD, but there are many other disorders within this category. So these come from exposure to traumatic or stressful events, or even hearing about them, knowing about them happening to someone close to you. There's those intrusion symptoms, thinking about things, flashbacks, nightmares, trying to avoid thinking or talking about it, avoiding activities or places that are reminiscent of it, kind of feeling on edge, hypervigilant, looking over your shoulder, being startled, changes in mood to have a low mood, little interest in things, thinking negatively about yourself or others, and kind of changing the way you see yourself and other people, whether that's it's my fault or everyone is bad, no one can be trusted, changes in sleep and concentration, aggressive behavior, loss of interest. So that's pretty characteristic of PTSD. Then we also have reactive attachment disorder, which is a childhood disorder where the child is withdrawn to their caregivers. They don't show much emotion or seeking comfort in their caregivers, and this can be due to abuse or neglect. And on the other side, we have disinhibited social engagement disorder, where a child is overly friendly. They don't have any boundaries with adults, and say they're at the store, they will walk off with anybody and everybody who says hello to them. And that can be dangerous. And this is another sign of trauma and neglect. We also have acute stress disorder, which is that precursor to PTSD, occurring up to a month after the experience of a traumatic event. Then we also have adjustment disorders, which can be up to 6 months after a change or a trauma, where there could be some sort of depression, anxiety, or conduct symptoms. And then prolonged grief disorder. This is going back to using your clinical instinct to see, is this person reacting the typical way you would to grief, or is this continuing on longer than would be expected for the typical person? Going into disruptive impulse control and conduct disorders. These are linked by different difficulties in controlling behaviors, aggressive behaviors, controlling themselves, their impulses, and infringing on the rights of others and breaking rules. These can be threats to other safety and societal norms. And these are mostly childhood disorders. So an oppositional defiant disorder, it's characterized by an angry, irritable mood, being easily frustrated, quick to lose their temper, often refusing to comply with requests, arguing often, being disrespectful towards authority figures, vindictive, trying to get back at people, and not taking accountability for their actions. Then if oppositional defiant disorder becomes more severe, it can progress into conduct disorder, which is more significant. So there's that aggression to people and animals, there's setting fires, destroying property, being deceitful, stealing, and then serious violation of others, their rules, their social norms, just lack of empathy and care. And conduct disorder in childhood can be a precursor for antisocial personality disorder in adulthood. Although we're not talking about personality disorders today, we do know that conduct disorder or some sort of symptoms in childhood is required for an adult to be diagnosed with antisocial personality disorder. And then we have intermittent explosive disorder, which are those recurrent aggressive outbursts, kind of similar to oppositional defiant disorder, but there is not any sort of objective or reason that they're doing it that you can actually put your finger on. They're not premeditated. It's just that lack of being able to control their impulses and acting out on their aggression. And within this category, we also have pyromania and kleptomania. And the last category I'm going to touch on is substance-related and addictive disorders. And like I said earlier in the substance use section, this could be its own course because substance use disorders are very similar, but also have individual differences in their treatment and presentation than other mental health issues. So these are characterized by a craving for or development of a tolerance to and trouble controlling the use of a particular set of substances. So this can be anything from alcohol, stimulants, cannabis, inhalants, hallucinogenics, club drugs, opioids, and even in the DSM, they include caffeine and nicotine. So with substance use disorders, like we explored in the assessment, we're going to see what their use is like. Is it a daily thing? How often is it? Are there periods where they've tried to abstain from the substance and haven't been able to? Based on that determines what kind of diagnosis we'll give. Is it simply a use disorder, like alcohol use? Is there intoxication? Is there withdrawal? Is the use of a substance inducing another disorder? Or do they have a history of substance abuse? So maybe it's cannabis use in early remission or sustained remission. So now going into differential diagnosis. So this is the way that we determine the most appropriate diagnosis when there are similarities in different diagnostic criteria. So determining the most appropriate diagnosis for a client in order to inform the most effective and appropriate treatment. And these are the steps that we're going to go through individually in order to go through differential diagnosing. First, we're going to rule out malingering and fictitious disorder. This is basically us using our clinical instincts. Is this person being truthful? Is this actually happening? So malingering is when someone tries to deceive their clinicians or their providers in order to have some sort of gain. That might be medication or getting access to a certain treatment when they don't actually have those symptoms. Pure malingering means these symptoms are fully made up, versus partial malingering means there's just some exaggeration. Then there's also fictitious disorder where, again, they're trying to purposely deceive their providers, but they're not doing it in order to have any sort of gain, like getting medication. They're doing it due to a psychological need to play that sick role. And something we see often on TV is that fictitious disorder by proxy, when someone fakes an illness in someone else, like a child. With this, I tend to think of things like Gypsy Rose, where the mother was faking an illness in the child in order to fulfill her own psychological need to be that caretaker. Then ruling out substance use etiology. So pretty much at the end of every section of the DSM, it states that the illness cannot be attributable to the physiological effects of a substance. And this is because substance use and mental health illnesses often mimic each other, and as well as the withdrawal from them can cause symptoms that aren't pure mental health. Substance use and mental health can often be like what came first, the chicken or the egg. It's hard to tease out what came first if someone is using substances to self-medicate to cope with a mental illness, if symptoms are caused by long-term substance use, but doing our best to tease those out because they're both mental health disorders. They do often co-occur. It's very possible that someone has both a substance use and a mental health disorder. They're caused by many of the same genetic reasons. Many similar symptoms, risk factors, use the same neurotransmitters and dysfunctional brain pathways, and they can and often do cause each other. And I like to think about this as sometimes someone has never had any sort of mental health symptoms until they've used a substance. Say someone has never had a psychotic episode before and they use a substance for the first time and now they're having hallucinations and delusions. That wouldn't be a pure mental health issue. We would have to explore how the substance could have induced a psychotic disorder for them. Ruling out a disorder due to a general medical condition. There's many different medical issues that can cause mental health symptoms or look like mental health issues. And pretty much same thing as with substance use. Every diagnosis in the DSM says that a general medical condition must be ruled out prior to making a diagnosis of a mental health disorder. So that's why that medical section is very important, to know what kind of medical issues are also going on. So some medications can cause and impact mental health and behavior, like antibiotics, stimulants, opioids, cannabis, Parkinson's disease medications, anti-seizure meds, heart and blood pressure meds, and cough medicines. And not only can medications induce mental health symptoms, but certain medical conditions, even general ones that people often experience, such as in older women experiencing a UTI, might cause some sort of confusion or even hallucinations or delusions. That doesn't mean someone who's 70 is experiencing schizophrenia for the first time, because we know that's not the typical onset, it would be important to rule out any medical issues such as a UTI. Then ruling out a disorder due to a neurological condition. So neurological conditions such as issues in the brain can resemble psychological symptoms. So there's 3 different types of neurological conditions we're looking for. First is congenital brain damage, which can happen pre-birth as a genetic factor or be experienced during birth due to trauma. Then an acquired brain injury, which can come from a stroke, a tumor, cancer, being poisoned, choking, infection, or substance exposure. And lastly, a traumatic brain injury, that physical injury to the brain from a crash, fall, accidents, violence. And again, it's important to screen for this in order to see if they might qualify for a different kind of service. That might be like our TBI program, who specializes in treating the interplay between a TBI and mental health. And so some symptoms you might want to look out for if you're considering a neurological condition is a change in headache pattern, visual disturbances like double vision, partial vision loss, speech deficits like trouble producing speech sounds or difficulty with word comprehension, word usage, abnormal vital signs like blood pressure, pulse, temperature, being disoriented, memory impairment, fluctuating or impaired levels of consciousness, abnormal body movements, frequent urination, increased thirst, or significant weight change, and a sudden onset of hallucinations or delusions that hadn't been there before. And then a progressive decline in cognitive performance, if looking at if it's more progressive or if it is happening more rapidly. And then selectivity of impairment, looking at how things are being impacted, is in every area of life or just certain areas of life. And then going into differentiating between adjustment disorders from residual or unspecified. So like we talked about in the trauma category, we have adjustment disorders, which is a reaction to any sort of change or even trauma. The symptoms can start within 3 months of an event and last for up to 6 months. So deciding, is someone having a reaction to a change or stress in their life that doesn't necessitate anxiety or depression because it is a response to a certain event. So there can be adjustment disorder with anxiety, with depression, with disturbance of conduct, or unspecified if you're not quite sure where it falls, but there is something that's changed or is going on after this client has had a change in their life. We're also looking at unspecified, where maybe we know someone's having anxiety symptoms, but we can't quite fit them into a particular category of generalized anxiety, social phobia, or panic attacks. Here we're going to notate the unspecified to say, okay, they have anxiety, but it's unspecified. We're not sure where it fits. And the person continuing to work with them can continue to explore this to see what's the most appropriate and best diagnosis for them. And lastly, rule out diagnoses. This is something I love to do because in an assessment, we only have, 1 to 2 hours with the client. We're not going to get the whole picture and everything we need to give a definitive diagnosis. So oftentimes they might give us some information on things they're experiencing that don't meet full criteria, such as post-traumatic stress disorder. They might have intrusion symptoms and avoidance, but not any sort of changes in their cognitive status, things of that nature. So you can put a rule out for post-traumatic stress disorder for their future providers to continue to look into this to monitor it. And then establishing a boundary with no mental disorder. That's going back to that gut check of, is this person reacting how we would expect someone to react? What's expected to be a typical reaction? Or is this to a level that is actually impairing their social, occupational, or other areas of functioning? That's the biggest thing when it comes to mental illnesses, is making sure there is an impact on their functioning. So making sure that they meet criteria, or if they're doing something that you would expect them to do. So sometimes it could just be an adjustment disorder or a normal reaction to, stress or trauma. And in the DSM-5 text revision version, there are diagnostic tables and flowcharts called decision trees that can help us differentiate between different symptoms and disorders to come to a more conclusive diagnosis. because we know there are many symptoms that are characteristic of the same diagnoses. So this is only part of a decision tree that I have here, but for example, suicidal ideation or behavior, you would kind of follow the flow chart down and see what applies to your client and what doesn't to give the most appropriate diagnosis. So even down here at the bottom, is it occurring in the context of a clinically significant depressive symptomology without clinically significant manic or hypomanic symptomology? So following that, maybe yes, maybe no, to see if it's related to a medical condition, substance-induced, with schizoaffective or persistent depressive disorder. So those can be super helpful if you do have a DSM-5 text revision version to go through those and look at what differentiates different diagnoses. So now we have 2 case studies that we're going to practice doing differential diagnosis with. So go through and read the case study and put in the chat some of the diagnoses that you would consider for this client. I know it's not a large amount of information, not enough to make a definitive diagnosis, but I would love to hear some of the things that you would consider for this client. All right, I'm seeing a lot of good stuff come into the chat, and there's no right or wrong answer here because, like I said, there's not enough for a specific diagnosis. But like most of you guys said, I think major depressive disorder could be a potential, as well as that adjustment disorder. I don't know if anyone thought that bipolar disorder could potentially be a factor. I know we don't have enough for that diagnosis, but maybe continuing to explore that if there are any sort of bipolar symptoms. Still seeing the MDD adjustment come in. And I feel like that can throw us off because we do have some different things going on. So she's 14 and she began cutting at 12. So that's already 2 years. So we do know that there's some sort of depression or mood instability going on for 2 years. However, she's been feeling down for the last 3 months, feeling down every day, and recently had that feelings of self-harm and difference in concentration, as well as lack of interest in activities. So I could definitely see both MDD and depression. I see in the chat, are we wrong to simply not give a diagnosis due to lack of information? No, I don't think that's wrong at all. I don't think you would give an actual diagnosis based on this client because you don't have enough information. However, I know if you were in assessment with them, you would be continuing to ask additional questions in order to give an appropriate diagnosis. This is just practice to see what your initial thoughts might be to have different diagnoses that you're continuing to decide between. I also saw a few people in the chat mention trauma, which I also think would be important to assess for to see if there is something related to trauma going on. Some aspects of separation anxiety because she does feel safe at home. Yeah, that could be true. And I would be curious to hear more about her relationship with her biological mother, who's not there with her, and instead her stepfather is there. I see. I thought we didn't use rule outs. I know at Western Tidewater with our initial assessments, we do use rule outs, although that can't be the primary diagnosis because we do have to have a diagnosis to bill. Yeah, and she might not realize what depression actually means. We would want to go more into psychoeducation to show what depression can look like, what it can be. Excellent. So I have one more case study for us. All right, so go ahead and do the same thing in the chat when you're ready. All right, I've seen a lot come into the chat, mostly adjustment disorder, which definitely sounds like it could be because she's had a lot of changes recently with her parents' divorce, although it doesn't say when the divorce was, it just says recent. Change in her relationship with her boyfriend, challenges making friends. Yeah, all these different changes she's had, as well as there could be some PTSD, like people noted. Let's see. And I saw some people put ADHD as well, and that unresolved grief. I think that's important to note too, that grief doesn't have to necessarily be the death of someone. It is that loss of a relationship, of the divorce of her parents, just some other potentials I looked at, like we said, major depressive disorder. There could be post-traumatic stress disorder because we don't know her trauma history. We don't know if something else going on could be triggering these emotions. Generalized anxiety disorder, and then adjustment disorder, like you all said. And I see she would benefit from individual counseling. Yeah, anxiety. Yeah. So a lot of good thoughts. Any other last minute thoughts? Is there a chronic adjustment disorder? No, their adjustment disorder can only be up to 3 months. If they meet criteria, it could go into a PTSD or maybe an unspecified trauma disorder if it didn't meet PTSD criteria.